Hey guys, I have a patient, 10 years old, African American, born on May 19, 2012, come to the clinic with his mom, and they are very good historian. The mother has health insurance, they will pay the copay. And the chief complaint is came in for sore throat and a fever for 2 days. And the patient has been in good health until like week before his appointment. Suddenly developed sore throat, and he was characterized. The pain is like very sharp pain when he swallow. His mother noted like he's unable to eat well, and significantly he lost the appetite. And the sore throat is very like, aggravated by eating or drinking, uh, especially cold stuff. Patient complained of fever previously for a couple of days and take Tylenol over the counter. Sudden intermittent fevers with spells of like kind of chill, especially the fever is very aggravated, getting worse during the night, especially after the uh, dinner. Uh, there is no shortness of breath, no cough, no runny nose, and the physical exam like no lymph nodes swollen, and the current medication he's taking is only Tylenol 500 and Q4 to Q6 sometimes. And he got history, never been hospitalized, no history of any chronic history. Family, they are very well and both employed. They don't have any family history, no social history. They don't have like no smoking, no cigarette, no drug. And he is the only child. He is in school, in fact. And immunization is very up to date. And the patient just looks like good. No, really, it doesn't look sick. Vital sign is very stable. 113 over 76, heart rate is 77, respiratory 20, PO2 is 95, temperature is 97.6. Pain is only when he swallow. Other than that, his BMI is 20. The physical exam is the patient's appropriately like aware of his surrounding. He's NO4, no complaint of pain right now except during swallowing, and there was eyes are okay, ears are okay, no problem, no drainage. His lacrimal duct is entirely intact, and the nose is nasal mucosa is inspection, everything is good. The throat throat is tender, it's wet buccal mucosa, shows redness, but there is no tonsillitis sign like any exudates or any pus is evident during the mouth inspection, and no evidence of larger tonsils was seen. There is no evidence of malignancy, thyroids, and no swelling, and there is no evidence of tracheal or mediastinal deformation. Lungs are clear, and my differential diagnosis was, since the patient is only like couple of days, evidence-based is a common cold, evidence-based history of the fever and sore throat, sometimes cold can cause such kind of, that's why upper respiratory tract infection, their main focus, like mostly pretty much they have the same symptoms. My second differential diagnosis was streptococcal pharyngitis, evidenced by history of fever and a sore throat. Streptococcal pyogenes is a member of a group A bacterium. It is responsible for oropharyngeal streptococcal pharyngitis. Possible source of gram-positive cocci is very epidemic between fall and especially late fall to winter. And at the same time, for school age, between age 5 to 15 is very common and very contagious. They can like spread through touch or sneezing, even coughing with droplets. They are very contagious before even developing the symptoms. And like this patient is they can cause a fever, painful throat, general malaise. He got nausea but no vomiting. The third differential diagnosis is Epstein-Barr virus, which is evidenced by the history of fever and sore throat. All of them, pretty much, they have the same symptoms: cold, streptococcus, and Epstein-Barr virus. Pretty much all of them, they have fever and sore throat. But we can rule out, because a kind of that may be found in human beings, malaise, fevers, swollen lymph nodes. He doesn't have swollen lymph nodes or neck, enlarged spleen and liver when it's especially disseminated in the organ. So my final diagnosis is going to be like streptococcal pharyngitis, which is the patient is positive with rapid streptococcal antigen test. We did the rapid test and it shows positive. So that's why we ruled out both of them, and we treat for streptococcal pharyngitis. And we did additional lab like CBC, because like a complete blood count occasionally to check ESR, and the finding is like erythrocytes was confirmed be normal, and rapid streptococcal antigen is positive for that. And monopath test is a diagnosis of Epstein-Barr virus. We didn't do this one because since the patient is positive, but the therapeutic plan is just to give a penicillin 500 milligram twice for 10 days, and the patient is okay. He's not allergic to any medication. So the education is the most important, especially family education is very important for streptococcal pharyngitis, because if the patient, if always the kids, especially pediatrics, develop such kind of symptoms, it's better to bring to the clinic very early, because if they come late, it can disseminate it to the organs like kidney. They can cause to the heart rheumatoid fever, like it can cause acute kidney injury too. So that's why we have to give education while recovering. The patient should eat like soft food, take medication on time, and it should have to finish the medication to eradicate and to prevent the relapse. That's the most important education we have to give the family. Some families are, if they take medication, antibiotic for a couple of 3 days, 4 days, if the patient is, they feel good, they stop the medication, it can relapse. So we have to do this one. And it's very common, like we have to patient like a painful throat, try drinking some warm liquids and soup, and at the same time, like they have to make sure when they hang out around not to transmit the disease. And we have to tell them come back, like follow up after 2 weeks. Thank you so much. Any comments, you are welcome. Thank you so much.